Well, I'm back. It's kind of funny how you become junior partner of the practice and they ask you to do 2 talks. So now I get to talk about carpal tunnel syndrome, very common. Who in this room has had carpal tunnel syndrome? Who's had it treated surgically? So a fair amount of you. It is the most common neuropathy there is. About 5 to 7% of the population. I think that's a little bit higher, but then again, my hand surgeon, so this is what walks in my office all the time, so probably good referrals from you guys as well. Oftentimes it's bilateral. Some patients may not notice symptoms in the other hand as much because pain is a distracting symptom, so they'll be focused on their dominant hand. If that's the one that have more symptoms, then they'll kind of forget about the other hand. Sometimes we'll see that after we treat one hand with surgery, they come back really concerned about the other hand because they didn't notice how much symptoms they had in the other hand. Again, more common in females. It's a major cost of US dollars for treatment as regards to the number of missed days of work. The anatomy, kind of look at a schematic here. The carpal tunnel is really a fibroelastic tunnel. It's made up by the dorsal wrist bones is here. The thumb's off to this side, the hook of the hamate is here. The FCR tendon has its own fibrous sheath. It's not in the carpal tunnel. So you have the 9 flexor tendons, and you have the innocent nerve. The nerve's the most volar structure. So if you have anything that takes up space in that tunnel, whether it be swelling, a mass, a tumor, synovitis of the tendons, it just pushes that innocent nerve against that transverse carpal ligament, and that nerve basically can't breathe, it can't get oxygenation, and then you have symptoms. Risk factors, there's a lot of them out there. Female, advanced age, renal disease, when we see patients that have systemic issues with fluid imbalance. Pregnancy is another one that there's a lot of fluctuations in fluid and maintaining balance, so there's a lot of swelling that can go on during pregnancy. And renal failure, we see carpal tunnel a lot with those patients. Rheumatoid arthritis, they have a lot of synovitis, so those tendons can get really synovitic, and the nerve basically takes the hit because it's the only thing that gets compressed in the carpal tunnel besides the tendons. Chronic repetitive activities, we get asked about this a lot. Is there an etiology of people that do typing and stuff for a living? I wouldn't say it's an etiology or it's causative, but it definitely is a risk factor for having it. Etiologies, a lot of it's idiopathic. Synovitis is the most common known cause of carpal tunnel syndrome. Again, anything that takes up space in that tunnel is going to cause carpal tunnel syndrome. So people that have gout, I always ask about if they have problems with their big toe or their knees. Tumors, obviously. One of the most common anomalous muscles that we can see during the surgery is actually a palmaris longus profundus. You'll see a muscle belly, just kind of ulnar to the palmaris longus in the tunnel. And if you remove that, obviously you make more space for the nerve, and the nerve can breathe again. Systemic conditions, diabetes is very common. Thyroid issues, I always ask about these in my patients. Traumatic conditions, so carpal dislocation or distal radius fractures. This is kind of an interesting topic. If I have a patient with a distal radius fracture that needs operative treatment, I always ask if they have a history of carpal tunnel, as it's probably more likely to come back in the postoperative period, and then you're seeing a patient that's doing well in therapy, but now their carpal tunnel is exacerbated. So if they have a history of carpal tunnel or numbness and tingling at the time of surgery, I will do carpal tunnel release at the same time. Therefore, I'm treating 2 problems at the same time. If we look at the nerve histology of carpal tunnel syndrome, there's no inflammatory cells around the nerve. It's more of a fibrosis or edematous problem around the nerve. There's no real inflammatory cells. So sometimes that'll be a test question on like CHT type exams. So chronic pathogenesis, idiopathic is the most common. Anything takes up space or anatomic, systemic conditions we already kind of talked about, and then the exertional type activities. So a lot of the mechanical labors that are doing vibratory type stuff, lawnmowers, or the concrete packers, those precipitate carpal tunnel. Symptoms, there's patients that come in, they tell you they have numbness and tingling and night pain. That's very nice for me. It makes a nice short visit. We know what the diagnosis is. It's very classic. But other times, the patient comes in with a history of fibromyalgia. They have pink hair. They have tattoos. And so I've noticed, this is not really in the textbook, but a lot of times you'll see these patients complain about tightness in the hand. They'll wake up in the morning and they just feel like they can't move the hands. They may or may not have some nighttime symptoms. I always ask about holding a cell phone or driving. If they have to shake their hands awake or hang their hands off the edge of the bed at nighttime to wake their hands up. The reason I tell patients that happens is at nighttime the blood pressure goes down. You have a little bit of swelling in the carpal tunnel. Basically that nerve can't breathe and get oxygen at nighttime. So it produces symptoms at nighttime. You wake up, you basically exercise the nerve, you're shaking it awake. You put it in a dependent position, you get blood flow back, your symptoms go away. So that's probably the most common presentation you see. Sometimes you'll have patients with wrist pain as well with carpal tunnel, but a lot of times they'll describe this occasional ache up the arm. I've had a couple patients tell me it radiates all the way up to the shoulder. So in those patients, I'm thinking about maybe an EMG nerve conduction test or a carpal tunnel injections to prove they have carpal tunnel before we go out to surgery. Symptomatology we just talked about. Some patients that are older may not notice they have numbness and tingling because it's such a gradual process. They'll come into my office complaining of pain. They can't sleep at night, they're pretty miserable, they have this hand fullness, and they may even have hand swelling. It's nice if they come with EMG nerve conduction test, but that's not always the time, but a lot of times it's just based on examination. A lot of these patients will have atrophy of the aperture pollicis brevis and numbness on your exam, and they didn't even notice it because it's been going on so long, and it's kind of a gradual process. The interesting thing about carpal tunnel is there's no real nice sequence of symptoms. So usually the nerve gets compressed. If you look at the nerve on topography studies, if you cut the nerve and look at the fibers that are most volar, that are against that ligament, the middle finger nerve fibers are most volar. So that's probably the most common finger to go numb and tingling first, and the thumb is usually the next one. Usually you have night pain and numbness and tingling, that nerve gets compressed, but they don't always follow that same sequence. So I had a 92-year-old female come to my office, no complaints of numbness and tingling, couldn't sleep, pain. She's kind of a sassy old lady. And she's like, "What are you gonna do for me, doctor?" And she had a lot of hand swelling, she couldn't make a fist. She came with the EMG and nerve conduction test that showed severe carpal tunnel. Her exam, basically her thumb looked like this, and her symptoms were pretty classic on examination for where she had the numbness, thumb, index, and middle finger. A lot of patients will actually tell you, if you ask them, where do you feel the numbness and tingle, they'll say the entire hand. When you really focus on that small finger, they don't have symptoms in that small finger because that's from the ulnar nerve. So again, she had no sensory response in her EMG nerve conduction test. She had delayed motor latency and velocity, and she had fibrillation and positive sharp waves on her EMG. So she was in the severe category for carpal tunnel, but the only symptom that she really had was pain. So what I did with her was, because she couldn't make a fist, I got her going with some therapy and an edema glove right away. I did a carpal tunnel injection to prove that she would get better with carpal tunnel. We'll talk about that in a little bit. And then ultimately she needed a surgery and did great with that. So prognostic indicators. Night pain is actually a good thing. I think it's one of the earliest symptoms you have with carpal tunnel, so it's one of the easiest things to go away after treatment or after surgery. This is a big thing for me. If they have relief of their symptoms with the carpal tunnel injection, it's very diagnostic and prognostic if they're going to get relief with surgery. So if I have a patient that's pink hair, fibromyalgia, has pain all the way up the arm, but she does have some complaints that I think is carpal tunnel, but her exam's not really consistent, I will do a carpal tunnel injection. If they get no relief, then I'd probably move on to nerve tests to prove it or disprove it. If they get great relief, then it kind of confirms your diagnosis. Poor prognostic indicators, if there are severe changes on the EMG nerve conduction test, they will likely not have complete resolution of their symptoms after carpal tunnel surgery. About 20% of the year will still have symptoms, and the older you are, the older the nerves are, and the slower the recovery. So I tell patients that at a year you may still have some symptoms, but they're definitely better. If they're work comp, we kind of talked about that throughout the conference as well. They're a little harder to treat. So diagnosis it's a clinical diagnosis. We use EMG of nerve conduction test to help us. I use the carpal tunnel injection to help augment the diagnosis if it's in question. Splinting can be helpful. Most over-the-counter splints that you pick up for carpal tunnel are in a resting extension position, which is the most functional position for your wrist. But when you look at pressure studies where they actually put a pressure transducer in the carpal tunnel and look at the wrist position with increase in pressure, it's basically the lowest at 0. So anywhere from 0 to 10 degrees extension is lowest. So if you got a cock-up wrist brace that puts you at 30, you're kind of actually increasing your carpal tunnel pressure. So a lot of times I'll tell patients if they have that and it kind of works, kind of doesn't, I'll tell them to take that metal stay out of it and flatten it out so it's more of a neutral type splint. So that's something easy to try. Physical examination, again, Tennell's, Phelan's, and Durkin's compression tests are probably the number 3 that I do. The Durkin's compression test I will kind of do with the Phelan, so I flex the wrist as well as put pressure over the carpal tunnel. And that's actually the most sensitive exam test that you can do besides the Sims-Weinstein's monofilaments. I think that those tests are very good, but they take a fair amount of time to do in the office, so they're a little bit harder to do. Here's just a chart for your review if you want to look at other examination findings. So the Tennell's on the right, you tap on the nerve. If they get proximal electrical shocks or distal electrical shocks, it's still a positive test for me. Usually it's into the middle finger or thumb. It usually never is in the small finger. And then Phelan's test is on the left there. Again, there's 4 muscles that the median nerve innervates. I remember them as LOAF or LOAF. The lumbricals of the index middle finger, the opponent's pollicis, the abductor pollicis brevis, and the flexor pollicis brevis. The one that you really test and can isolate well is the abductor pollicis brevis. And I usually ask patients to point their thumb at the ceiling, and then I'll test the strength of that muscle. EMG and nerve conduction test, I don't think you could ever be asked to read this. Numbers that are easy to remember are 3, 5, and 4, 5. So I tell patients it's kind of like looking at the electricity of a wire in the wall. If the wire is being pinched in the wall, the outlet's not very hot, so the neurologist will basically look at the conduction or speed that it takes the stimulation across the wire to reach the outlet. So if they have a sensory latency greater than 3.5 or motor latency greater than 4 or 5, that's positive for carpal tunnel. If they have any EMG nerve findings, that basically puts them in the severe carpal tunnel category. Treatment, I usually always start with first-line non-operative treatment. A lot of times they're primary care physicians that get on night splints, and usually that's for a couple of years or a couple of months, and it's now failing. Nerve glides, I think we'll talk about upcoming. Carpal tunnel injections for me are great. I think that 80% of people have a transit response or improvement of their carpal tunnel symptoms, and this can be seen within a week. So, carpal tunnel surgery, there's a lot of surgeries out there. There's mini open, there's the traditional, there's the extended, endoscopic, and there's even ultrasound guided now. This kind of started over in Spain, and a lot of ultrasonographers are now moving towards that. So we may see more complications from that as hand surgeons in the future. Pregnancy or breastfeeding is not really a contraindication to getting a steroid injection for me, but I will kind of consult their obstetrician or pediatrician for an opinion. So I know if I get a patient from Mid-Dakota Clinic that they're okay with their patients getting a carpal tunnel injection, even though the steroids are category C. Outcomes of surgery, I usually tell patients full grip strengths return in 3 months, pinch strength 6 weeks. Usually the first symptom to go away for them, which they love, is the nighttime pain. Even the day of surgery, that nighttime pain is usually gone. The numbness and tingling is usually the next symptom. So If they have severe carpal tunnel in the EMG, it can take a year to improve, especially if they're 75. If they're moderate carpal tunnel, about 2% of patients may still have some symptoms. By post-op instructions, they're in a soft resting after surgery. They're kind of doing light activities. It usually stays on for 3 days. I usually say 2 pounds for 2 weeks because it's easier to remember. If the patients do too much, they're just going to create more swelling, inflammation, and pain, and then I have to give those phone calls for them in the office. So I do mine mostly endoscopically. I do bury the stitches, so there's no stitches to remove in the office. Patients like this. And we talked about that earlier. Expectations are kind of listed here. We talked about the night pain usually going away first, the tingling's the next symptom to resolve. I have had a couple patients, if they're younger, in their 30s and 40s, as the nerve kind of reinnervates or heals, they'll actually have this rebound pain 6 to 8 weeks out from the surgery, where the nerve's kind of reinnervating, and they may have more symptoms at that time. You just have to counsel the patients that that will go away, so Tylenol, ibuprofen during that time period is helpful. Revision carpal tunnel. If I have a patient that's had a carpal tunnel release in the past, if they've had a small incision, that's been noticed in the literature that that's a good thing because that means they had it endoscopically, which I do. So the thought was the most common complication of an endoscopic carpal tunnel release was incomplete release. So if Dr. Pierce sees a patient of mine, he's probably happy if they have a small incision because then he'll say, oh, an incomplete release. Right, Dr. Pierce? So another good thing, if they've had carpal tunnel and it's back, I will do a cortisone injection. If they do get relief from that, then I usually counsel them that will get relief from another carpal tunnel release. The chance of recurrent carpal tunnel is about 10%. The outcomes after revision surgery, usually 50% get some improvement, 25% get full relief, and 25% get worse. So the more and more you go in there, the more scarring you create, and the more that nerve can be scarred in. If they've had an endoscopic carpal tunnel release, that's a contraindication to doing an endoscopic again. You just go to standard open at that time. Complications are listed. Pillar pain. I generally see less pillar pain with the endoscopic carpal tunnel releases because you're cutting less tissue. There's not an incision in the palm. That's kind of been borne out in the literature. But then again, if you're doing a mini open carpal tunnel release, they also have less pillar pain too. So it's kind of whatever's best in the surgeon's hands. So this is the endoscopic carpal tunnel release device that I kind of do. So just ulnar to palmaris longus. I'll make a small, about 1 centimeter incision in the wrist crease. It hides the scar really nicely. I'll create a flap of the antebrachial fascia. I'll elevate the undersurface of the ligament with kind of a freer elevator or a dilator into the carpal tunnel. You can usually see the end of the transverse carpal ligament very well with the scope. Everything's nice and blown up. I think one advantage of endoscopic is there's different takeoffs for the recurrent motor branch in the carpal tunnel. And sometimes you can see where that comes off when you're doing it endoscopically. So if you see that little motor branch coming off, you can kind of cut around that and avoid the recurrent motor. On average, there's about 2 weeks faster healing time with endoscopic. Again, it just depends on what literature you read. Ultrasound guided. I did a few of these in fellowship, kind of an interesting technique. You had to have about $100,000 ultrasound machine to read the nerve tissue that well. It was very minimally invasive, 2 millimeter stab incision. Patients got better very fast. The research behind this is that we don't think that we have to fully release the transverse carpal ligament now. They've done literature on this, and there's 3 different layers to the ligament now. So the deep and distal parts of the ligament are what we think has to be released now. So as long as you get distal and the deep fibers, patients get better. I don't know how that corresponds to the incomplete release after endoscopics. I think that just is recurrent carpal tunnel. So what's the best technique for carpal tunnel release? I think it just depends on the surgeon. I think that if you ask Dr. Bob what's the best approach for a total hip, I think it's just different in each surgeon's hands. If you see a billboard for an anterior hip replacement, you don't want to post your hip guy doing his first anterior hip replacement. So if a surgeon has high success rate with an open carpal tunnel release, you don't want to ask him to do it endoscopic. So these are our AOS clinical practice guidelines. You can read through them. I kind of summarize them throughout the talk. So questions?